Good evening, everybody. Thank you
Gentlemen, how are you?
for joining us tonight.
Hey,
Yes, this is Braxton College's live webcast. We do this actually the second and the fourth Wednesday of every month and with a different topic. So my name is Bill McGrath. I'm the Vice President of Academic Affairs here at Braxton College, and I'm very happy to have our guests on for this evening. So we're here to talk about patient outcomes, really improving our patients everywhere from dispatch all the way to the ER and even into the ER. So tonight we have Dr. Roach, Dr. Jim Roach. He's the medical director of Broward Sheriff's Office down here in South Florida, as well as Fort Lauderdale, City of Sunrise, and at Cleveland Clinic Weston, correct? And I also have Dr. Tony Gandia, who happens to be our medical director here at the college, but he's also the medical director for the city of North Lauderdale, Margate, Coconut Creek Fire Rescue, and with Mount Sinai Medical Center in Miami Beach and in Hialeah. Thank you, doctors, for spending your time here. I think we have some great topics to talk about. I'll let you introduce yourselves, and we'll start with our real guest, Dr. Roach. Dr. Gandia, you're our inside guy. So, Dr. Roach, thank you again for joining us tonight.
well, listen, I have to jump in first because being the guy with the gray hair, I'm always jumping in. But I got to have personal pleasure and honor to be here with Jim. He, believe it or not, he was one of my residents at Mount Sinai. And I was just talking before that I'll take 1% of the credit because I think we gave him the bug in EMS when he started riding with us on the streets of South Florida. And I couldn't be prouder and honored to have him here with us.
Thanks, Dr. Gandia. I appreciate it. And Chief McGrath, thanks for the opportunity to be here. Dr. Gandia, it was always a pleasure working with you and your mentorship. It's gone a long way for me, and I'm always going to be grateful for it. So I appreciate it.
Thank you so much. So we're looking forward to tonight. So, Dr. Roach, obviously you're the medical director of some big systems down here in South Florida. We talk to fire rescue agencies all around the country, and it's such a hot topic that we want to improve ROS rates, right? Everybody's looking at what is new. How do I make a difference to our cardiac arrest patients? You took it the one step further, at least in South Florida, and changed it where it starts, and that was dispatch. And I think that makes such a big difference in patient outcomes. Please share what you've done and all the great success you've had.
Absolutely, Chief. Thank you for the question. And dispatch has become my passion. I mean, I'll tell you, the first time I went into the dispatch office, they speak a different language. I mean, there's so many different acronyms and things. It took me a while just to get used to what they're talking about, the Pro QA and all the different things that they have, and which particular, like a number 9 is cardiac arrest and whatever, chest pain. Anyway, so you're starting to get used to this stuff, and then they kind of, with me, they really never had a medical director involved to say, I want to work with you to improve patient outcomes in terms of cardiac arrest. And so they're kind of, it was a process to get, and I think like everything in life, you have to develop rapport, a trust, it has to be built. So I think first is build trust with the team, let them know that you're here to bring value, to support them, to just be a colleague. And then the next step, I think, is showing them the importance of what they do. So I explained to them that this is the links in the chain of survival. And without this first link, no matter what we do at the hospital with ECMO, CPR, and temperature targeted management and PCI on every VFib arrest. I mean, if we do all of that stuff, we're not going to have success if we don't start pushing on the chest early and get that brain perfused. So they bought into that concept, and then then it was a matter of like every process, you have to get metrics and you have to create a process. Look at the metrics on a daily basis, weekly basis, monthly basis, and then start to just chip away at whatever inefficiencies that you can find within the system. I think you get something with just letting everybody know that we're measuring this. You get a Hawthorne effect where people say, oh, they're looking at this particular outcome, so let's get good at it. So we got a good bump just in the first 6 months, just from talking about it, giving them the why that this is important. And, so we got a big jump. We were running around 5-6 minutes for hands on chest. They look at there's the 5 major times. There's T1 through 5. So T1 through 3 is problem description until position to hands on chest. So I can give you those numbers, but we basically broke it down from about 5-6 minutes down to now it's running in the like 90-second range for cases with no barriers.
Wow.
So and that's another thing. So that's we started to realize when they're frustrated, they go, we can't get down to this because we have barrier cases. They go, what do you mean barrier? What do you mean? What's some of the barriers? Well, like Pro QA, they'll say, well, we're trying to get them off the bed to get them in a perfect position for CPR. And everybody wants a perfect position for CPR. But what happens when you can't get a perfect position? So you say, well, what do you do if, the woman's 100 pounds and her husband's, 300 pounds and a big man? She's like, I can't pull him off the bed. So what do? Well, then I had to work with them, the dispatch operators and the Pro QA leadership to say, what if we just start CPR in a less than perfect scenario, get what we can get, So that's kind of been the process of going through the barrier numbers. Say, okay, when we have barriers, what are solutions? Same thing with ventilations. So Pro QA has a protocol. In certain cases, they want to do ventilations first. So I said, well, it's fine that, for example, in a pediatric patient, ventilation first is the protocol before age 8. So let's say you try ventilations, but you can't, let's say that's not working out. At what point do you cut your losses and say, okay, it's better to do chest compressions than nothing. So try the ventilations when it's appropriate, but if you can't, let's move forward. And so I think that's been positive. They know that, look, we're here to support. The information is there, and it's come across as a positive thing. We do have our ups and downs. There's still calls. I try to go once a month to the dispatch and listen to calls with an operator and just go through the calls with her and, say, hey, what happened here? What can we do better? Going to their ACLS, when they do ACLS training, going there and talking to them about the importance of it. And then also, we recently got a great case from Davie Fire Rescue where there was a success story. So whenever there's a success story,
sure,
plug that back into them and say, look what you guys, you were a part of something bigger than just answering the phone. You make a huge difference in the community, and they appreciate that. And
I could imagine dispatchers are, I haven't spent much time with dispatchers, but from the other side, we have lay people that hesitate, right? They don't want to hurt anybody. They don't want to get involved, or they're afraid to get involved. But any medic that's out there in the street will tell you if our best days of response time of 4 minutes or 5 minutes, if there's no bystander CPR, our outcomes are not great. And, that type of plan of getting someone doing something, I'm sure the dispatchers originally were hesitant also about having someone start CPR unless they were absolutely sure, because they didn't want to hurt him either.
Yeah.
And, we're better now. They teach no signs of life. We're starting CPR. So I think we're past that, for the most part.
Yeah, absolutely. And
no, go ahead. I was going to say, like you mentioned earlier, listen, between, hypothermia, ECMO, this and that. I mean, I've been around where in the American Heart, I've gone through probably 10 different changes, right? Or every 3 or 4 years. And really, between beryllium, lidocaine, procainamide, high dose epi, I mean, still the most important thing is getting hands on chest early, no matter what medication we use, what high tech stuff we've been doing. That still is the constant variable that's so important.
Absolutely. Yeah. Right. And to Chief McGrath's point too, the fear of it. So I spent a lot of time with him saying, listen, you're going to hurt them by not doing CPR. I promise you. And that's another thing, building trust, as I said before. When they know that you got their back, you say, listen, I'll go to war for you. If you start CPR on somebody and there was they weren't in cardiac arrest, whatever the case is, they were hypoglycemic, and you started doing CPR and there was something that was considered not appropriate, I'm going to have your back. So go ahead and start CPR when they're not conscious and not breathing normally. Be aggressive with the chest compressions. To Dr. Gandia's point, without that, we're not going to make any headway in terms of long-term neurologically intact survival.
So for those that are watching and that aren't in South Florida, that don't get the advantages of what you're doing right now, where would they start? You talked about building trust. Obviously, as the medical director, you can steer that that big animal. What about the providers? What about the EMS chiefs? What about the fire chiefs? Which they can, but they need your buy-in. They need that medical direction to change that. So where do they eat? How would you recommend someone starting this program or improving their numbers?
Yeah, I would go right to the dispatch, find out the leadership, talk to them what you want to accomplish, go and talk to the operators. I spent a lot of time with pizza and donuts so that I had a reason to sit with the operators in their break rooms and just talk to them and, listen to what they say to me. They say, well, we want to help you, but the system is built so that I'll get in trouble if I don't do this. And I said, let me address that. Go to the leadership. Hey, they said they'll get in trouble if they don't. What's that all about? Okay, let's go back. And so there's a lot of times within any organization, there's just communication.
Sure.
Somebody thinks something's true, but it's really not true. Then they say, we're not going to get them in trouble. So let's get everybody together. So I would go have those conversations, build trust. Know that it's not going to be a sprint. It's going to be a marathon. You got to go every month. And a lot of times people say, hey, have you accomplished anything? Sometimes you feel like, I don't think I've accomplished anything. I feel like I'm just pushing forward. But what's interesting is there's these little breakthroughs that occur. And all of a sudden you're like, all that work, I didn't think I was accomplishing anything, but all those conversations led to something. Right. And then all of a sudden you start to see the breakthrough and the numbers come down. You go, okay, fantastic. This is actually working. And the more people that you can get built into the system, like I always use the Vince Lombardi-isms, the individual commitment to the group effort is what makes a civilization, a society, any team work. And so I always say, like, if we can get the more operators, the more people in leadership at the dispatch centers that are thinking about this and pushing it forward. And then I also say to the firefighters, paramedics, guys, if you can institute a policy where if you're at the north end of the county near the North Dispatch office and you popped in there wearing your badge and all, and saying how appreciative you are about the hands-on chest, and these people will love that. I mean, they will never. It's one thing when I do as a doctor, but when the paramedics come in, they love that stuff. So I've asked people in the community, go by the dispatch, even if it's for 10 minutes, and tell them, hey, listen, we appreciate it. You're part of our team and we really need you. That goes a long way. That's a huge step in moving forward. Measure data, constantly looking for it, finding the tweaks, separate barrier from non-barrier cases. So you'll find that barriers go pretty easy. Then there's other things that you can start thinking about. Like, for example, right now I'm thinking about how do I implement a prone CPR? So now there's a barrier. We can't get them off the bed or we can't get them onto their back in a supine position. What about doing CPR prone? So now, trying to look at data. Is this being done? ProQA is open to this suggestion and looking at the data. So that's something, maybe that's a solution for barrier cases.
Wow. Oh, that's great. That's really
wonderful.
So I definitely I commend you on that.
Yeah,
really.
I think, Jim, I'm sorry. I think, Jim, as you mentioned, just making them part, showing them that they're part of the system, that they're not just picking up the phone, speaking to someone, but that they're really making a difference. And just like us on the pre-hospital, when we take STEMIs or code and we don't get the feedback of what happened, you kind of lost. But every time you get a feedback, oh, that STEMI patient just left the hospital 3-4 days ago, is terrific. So bringing that back to the dispatches, as you said, knocking on the door, hey, you guys made a great call. This person walked out of the hospital, and if it wasn't for you, so forth. That goes a tremendously long way, and it really brings the togetherness on how that really, not to be sound sophomoric, but that chain of survival, how they really started, working on that and helping that out.
Yeah, they're not involved enough in the survive stories for sure. I think that'll make a difference. So let's stay on our cardiac arrest, right? Let's talk about how else we can improve. So you're trying something down here in South Florida. I know it's being used in parts of Canada, and you can kind of elaborate of really who started this, of epi infusions in arrest. So people are like, oh, we don't do epi drips. We don't do, drips in cardiac arrest. And it's more of an infusion. It goes back to that theory, and correct me if I'm wrong, of if I bolus people with epi and push and push and push, I'm basically trying to take a heart and make it go from 0 to 100, a heart that's already failing or has failed. So you're taking epi, putting it in a bag and doing a constant infusion. So you still get epi 1 milligram every 4 minutes or so, which is the ACLS standard. It's just not pushed so hard. The heart doesn't have to respond with such a high dose of epi or concentration, correct?
Yeah, I mean, you pretty much hit the nail on the head. So looking at Paramedic 2 trial, the summary of that in my mind is epinephrine is good for the heart, but bad for the brain. I mean, epinephrine helps improve ROSC, but neurologically intact survival is basically harmed by that. So, I looking at it, I'm thinking to myself, God, we have to come up with something to do. We've been doing the same thing, and there's nowhere where you can see, especially in adults, where epinephrine improves neurologically intact survival. So the question is why? Looking at other papers, I can send you circulation. There's a paper out of resuscitation that looks at timing of epi as well as the interval of epi. So it looks like if you extend the intervals out past 6-8 minutes, the survivability goes up, the ROSC rates improve, and then the earlier you get epi on board, the ROSC rates improve. And so then the thinking is, and this is a sort of a thought about epinephrine. If we don't give these spikes of epinephrine, we start a drip and we keep it steady state over the course of resuscitation, maybe the brain perfusion would be improved with that. So so that's the whole theory. And then the other thing is, and I'll talk about this when we go through the CQI stuff, but everything I do is a two-part thing. It's one, how do I improve outcomes for the community, which is my number one. And then the very close running number two is, how do I make the paramedic firefighters' jobs easier and better? So the idea of this whole pit crew CPR and coming in and establishing an airway that's a iGel, using IOs, Lucas or Autopulse, whatever your agency has, and then hooking up an epi drip that you can actually prepare in route. And so that's the thing. And so it's rapid on. And so my paramedics that are using this are saying, look, this makes life so easy.
Sure.
And that's what I want. I want you to be able to get through the primary objectives of pit crew within that first 6 minutes or so. And then use your minds to be able to analyze the situation, look for the H's and T's, look for other things that are reversible causes, what's happening. And your mind is off dosing medicines. The epi's running, everything's good. Now, the way we do our epi drip is we give 1 milligram of epi for every 50 cc's. We put that typically in a 100 milliliter bag, so it's 2 milligrams of epi. We run it at a 10 drop set, 1 drop a second. So they end up getting about 1 milligram every 8 minutes. So it's actually a little bit less than, ACLS, but
right.
There's room for between 0.5 milligram and 1 milligram every 5 minutes.
Okay.
So we give 1 milligram every 8 minutes. It's a little less, but I think that's okay. I mean, I think that's reasonable in terms of the amount of epinephrine. And I've spoken to a lot of cardiologists here at Cleveland Clinic, and they support that as well. So they think that's definitely reasonable to look at. And so our ROSC rate has been about the same. Neurologically intact survival is what I'm really looking at. It's kind of a new protocol for us. So I'll be interested to see what happens in 2021 and 2022. So I can come back and say, hey, this made a difference in neurologically intact survival. Because again, that's our goal.
And it's been used, right? They've done studies for the same infusion, right?
Yeah. Yeah.
There's been quite a few agencies. I know the one is Toronto or Quebec or someone there was doing that along with anterior posterior pad placement to decrease that thoracic resistance that seemed to have some benefit as well.
Yeah.
Really still doing the same thing we're doing, just in a different format.
Right. Exactly. So, and then the other thing is with this is we could do this in pediatrics. And I talked to Dr. Antevi about it. And it's, again, very simple. You take the pediatric dose, you double it, put it in a 100 milliliter bag, and you run it. Same 10 drop set, 1 drop a second. So now your paramedics, they go, well, if I'm running a pediatric code or adult code, it's a very similar process. Everything's, so it takes the fear away from a pediatric patient. And we think that adds value, so.
That's a great idea. Have you seen anything like this in the emergency departments, either of you?
So what I'm doing in here is at the Cleveland Clinic is we take the same dose of episodes. 1 milligram runs every 5 minutes as an epi drip. We have this protocol here.
Okay.
And, everyone's on board with it. So for the same principles, just ease of use. And, it's doctor preference. Unlike in the pre-hospital setting with paramedics, you can make a protocol and follow it. Yeah. But licensed independent practitioners can do kind of what they want to do. So right. I give this as an option. Hey, if you want to use an epi drip, it's here and makes things easier. So most of them do use it. So,
sure.
Yeah. I remember when we were using the vasopressin, right? Which was, hey, we give a shot of that. We don't have to worry about it for another 10 minutes, which is similar to what we're doing now. And then when you talked about, the drip at 1 milligram, every 5 or 6 minutes, it's not 1 milligrams every 5 or 6 minutes. It's a total of that 1 milligram throughout those 5 or 6 minutes.
Right. Yeah, exactly. So, hopefully that epi drip does add value both in outcomes and in patient and in paramedic satisfaction, job satisfaction, makes their jobs easier. And then the next step from the epi drip is at some point talking about heads up CPR, which I know Keith Lurie, and they've done it in Palm Beach County. So that's maybe something to think about down the road. And then, if you get ROSC, instead of shutting the epi drip off, which is what we currently do, there may be opportunity to make a protocol where you tune back the epi drip to 1 drop every 4 seconds to support post-ROSC hypotension.
Right.
That may be something to think about as well.
Great.
A lot of stuff on the horizon, brother.
Yeah, it's amazing where we were and where we've gone. And we've talked offline, and I think everything that you're doing, and it's going around the country, and congratulations on becoming one of the Eagles, by the way.
Oh, yeah,
those that are watching that have never seen the Gathering of Eagles, it's really the medical directors from all over the world. Dr. Paul Pepe runs that, and Dr. Roach has now become one of those Eagles.
Congratulations.
Which is a big deal. And you can see the Eagles at our conference right here in South Florida, June 14th, 15th, 16th. So there'll be a great conference.
I would be remiss without saying what an influence Dr. Pepe's been on my life and career. That he really is a genuine great human being, just a kind guy, brilliant guy, and always wants the best for everybody around him. So he really is and to have him in Broward County right here with us, it's incredible.
Yeah,
it really is.
Yeah,
definitely on all these changes we're making. From a school perspective, I can tell you it's a challenge, everything that you guys are doing. We've been teaching paramedic school for a very long time, and there is a national standard curriculum, and they're tested on that curriculum. And everything is so new. We as providers try and bring that in the classroom, and it tends to confuse them, quite a bit, because that's not what they're going to be tested on in the national registry or their state certification exam. And then they're going to come into systems like yours and need a huge training regimen, all for good reasons. But they're not. They may be exposed to it, but it's hard for the schools to test on that, right? So those are parts of discussion, but it's so dynamic, which is great. And whether you go and not comparing systems to systems, but throughout the country, that standard isn't there. Those changes, that willingness to try and make those differences and analyze the data isn't as dynamic as it is here and other places in the country that are doing what you're doing. So that's a big deal. One of the other topics we definitely wanted to talk about that you're doing, and some other areas we do some training down in Monroe County, they're doing it as well, is blood products. So you're carrying blood on the helicopter, and you have some of the field units, correct, carrying blood. Tell us about that program you have.
Yeah, so that's another Dr. Pepe. Dr. Holcomb is the guy that Dr. Pepe brought in and sort of, introduced everyone to. He's a retired, I think he's a colonel. I don't want to underestimate his ranking, but I think he's a colonel. Anyway, he's a great guy, trauma surgeon. He came and did the memorial symposium talking about whole blood. And I was listening to this and I was thinking about it all. And personally, my niece was in a car accident and she passed away tragically with a liver lesion. And I was in my mind thinking, what do the paramedics, what do they have, that they could give in the pre-hospital setting to bridge to get a patient into the operating room? I mean, really, right now, what do we have? We have normal saline. That's really the only thing. And we know that normal saline is probably detrimental for hemorrhagic shock. And we hold it off and we do permissive hypotension until the patient becomes so hypotensive, they start to lose their mental status. And then we go ahead and try to resuscitate them the best we can. And so all of this was on my heart and thinking about it. And I said, we really have to do something for the community when this happens. So the whole blood is the answer. I mean, that's what Dr. Holcomb pushed. And I think all the trauma surgeons at Memorial and Broward's, everyone agrees that whole blood is the answer. I think the challenge for the hospitals is the logistics of it. I mean, it's difficult. And so I've been doing everything I can to help the hospitals and promote them and support them. It's just difficult getting that started. But so what we have right now is we carry 2 units of whole blood, and if we have a trouble getting one of the units, we'll carry plasma. So we have the whole blood, and we have a Quinn Flow, which is our rapid infuser, and we have the coolers and the refrigerator, freezer to keep it at 4 degrees Celsius. So we have all the logistics. It's not actually that hard to put all that together. It seems like a lot, and at first it was like almost an insurmountable task, but it actually got done, and we've been using the whole blood. Recently, we just had a case. Actually, today I got a phone call from the trauma surgeon at Kendall that we gave whole blood to. Somebody was in hemorrhagic shock from an amputation of the leg, and was brought into their trauma center. They had a BKA that was extended to an AKA, and the trauma surgeons told me, hey, this guy's going to make it. He's going to live. And we think there's a high potential that the whole blood probably bridged him, during that time of hemorrhagic shock. And so it's just great to see that it does work for certain. This was modeled off the San Antonio project, the San Antonio whole blood program. And we pretty much modeled it identical to them. They were the first ones, I think, in the country that have a whole blood system. And so in talking to them, they give whole blood, not just in trauma, but they give whole blood for medical codes, for GI bleeds, for vaginal bleeds, so non-trauma is a high percentage of their whole blood administration. So, which is why we really want to push it onto the ground and have our EMS captains carry it. And, but it is difficult logistically to get it all done. So an agency can also consider plasma. And if you have fresh frozen plasma, it actually, I don't think it's as good, but there's one of the trials from New England Journal of Medicine actually looked at a 10% reduction in mortality when given plasma for traumatic shock. Yeah,
and I've never been a big person, and Dr. Gandia knows, where you say, well, we're 10 minutes from the hospital. Well, you're not 10 minutes from getting blood.
Right.
There's a whole nother process that gets there. So the clock doesn't stop when we walk in those doors. So to me, even in a very highly populated area, this is still a great program. Even if you have a trauma center close by, this is still very applicable to your area.
Yeah, I see it as a similar thing. There's the analogy to why Dr. Shepke gives antibiotics in the field in Palm Beach County. Similar thing. If you talk about it, and if you know the hospitals, how long does it take the hospitals to give antibiotics to these severe septic shock? It could be 3-4 hours. Grandma's in the corner waiting for antibiotics. We'll get to grandma later, 3 hours later. And now every hour delay in antibiotics is a 9% increase in mortality. And so now, we've just caused harm. So in Palm Beach County, they're giving antibiotics in the field. And I think it's the same principle you're saying, because just because we get into the hospital doesn't mean they're going to get that life-saving intervention.
Right. Absolutely, Doc. And you're doing the same.
Yep.
I think one of the things that you mentioned, which was interesting, Jim, is the non-traumatic need for hemorrhagic shock. I mean, those of us who have seen, awful GI bleeds, from varices and so forth. I mean, those folks bleed out immediately. So something like that, the non-traumatic, because it's all trauma, but the non-traumatic medical need for blood is really out there. And like you said, just bridging that gap, like you just talked about that example, bridging that gap is so important, with that. So it's wonderful. Now, Jim, I was going to ask you, so how, I know, especially with the helicopter and all that, how do the guys and gals on the ground can prepare you for that, with the tubing and everything else? Is that something that we should talk about generally on a county level? Say, hey, we got the tubing done, we got the right IVs done, et cetera. So once the helicopter lands, the blood is immediately put in.
Yeah. Yep. So the Y tubing is something that does help with the infusion, because you can prime the Y, you can prime one side with saline and then hook up your blood. So that helps. It's not 100% necessary that you have Y tubing. The Navy SEALs teams, they'll give blood without a Y tubing. They'll give it straight line in. But the Y tubing does help. Having everything ready, I think that goes a long way. Having the general stuff packaged up, if they could be intubated before they go on the helicopter, that's helpful. So we get there. The other thing is, to save time, I've actually mentioned you could give the first unit of blood cold without going through the warmer. That'll raise the body temperature less than a fraction of a percent. So it's really not significant, especially when you're following with a unit of warmed blood. So the rapid infuser gets it to about 98 degrees within a minute or so. But again, we should be able to do that if need be in this critical situations without waiting for the warmer.
Now, are you being proactive with this, or are you waiting for someone to show signs of severe hemorrhagic stroke? And the reason I ask that and leads us into our next, we've been carrying ultrasounds for quite a while. We've had the Butterfly IQ ultrasounds where we could do a fast exam and see if someone is bleeding, and they may be compensating. You're going to need blood. Do you wait? I mean, until they really need it, or are you doing it prophylactically even?
So that's a great point. What happens is the firefighter paramedics, they're very, I noticed a lot of the most critical people get the whole blood. So it's like people that are in cardiac arrest, trauma, they want to, but I said the blood's going to be most effective for the people that aren't quite yet in arrest, of course, or in, those late stages of shock. So how do you pick that up? I mean, the first stage of shock is just anxious. You're feeling very anxious, but vital signs look okay. We look for a shock index. So as soon as the heart rate and the systolic blood pressure are the same, so systolic blood pressure, or say heart rate's 100, systolic blood pressure is 100, that's when you start thinking, okay, this person is getting close to that. When it's above 1, so the heart rate's 100, systolic blood pressure is 90, that's when, you have things, and we have this set criteria based on age. So we have a lot more room to give with a lower shock index. But to your point, somebody comes in, they're slightly tachycardic, slightly hypotensive, but you slap on an ultrasound and you can determine there's blood in Morrison's pouch, and you see, now all right, let's get ahead of this. And again, you're getting ahead of, everyone knows in trauma, when you get behind, you're in trouble. But if you can get in front of it, give a unit or two of blood en route. And again, the unit of blood is 500 milliliters of whole blood. You can give that in a few minutes. So even the helicopter ride, and that's the thing, the trauma surgeons, we don't want you, the trauma surgeons will say, we don't want you delaying to give blood. No, we're going to give it en route. So you can give a couple units of blood, which is a liter of whole blood en route, and you just took that person from going into shock, those late stages of shock, to preventing it, and to give them that time they need to bridge to get to the operating room and so forth. So that would be
it's the perfect setting, right? We do, and there's a lot of ground units. There is a lot of agencies using ultrasound for just certain aspects, but they might not be taking advantage of some of the other programs like yours in their area that they can use that to take it to the next step, or to send the image to the trauma center and say, look, we see this, we're on our way, get ready. Don't wait for another exam. We're coming in with this. So our technology is getting there. And there's a great picture of the Butterfly IQ. And we carry these, and our rescue lieutenants can put it on their phone, or we have an iPad in the rescue for them to use, and give fantastic images. And there's a lot of ones out there.
Jim, you appreciate it, because really when we started looking at the ultrasound, the Butterfly was just when you were starting with the blood products, and we said, man, what a perfect setting, especially for blunt trauma, where those MVAs that, with those, seatbelt signs or a little abdominal pain, and we can really look quickly with that. So really, it was perfect timing for us, because that really got us excited when we heard about, it was really about the same timing when you were starting with the blood, that we were looking into our ultrasound. And you appreciate this too, Jim, as a resident of ours. The residents from Sinai came and gave all the training, the ultrasound training to the guys here and the guys at North Lauderdale. So it was great. And, we hope to expand that more and more as we go. And as Bill said, as Chief McGrath said, really, if we're able to collaborate with the trauma center, say, hey, we can send you these pictures right now, real time, as we're at the scene right from the Butterfly, which is almost like, the old sending the facts of the EKGs when we look at the studies. Really, here it is right here in front of you. So, be waiting for us when we come in. You're just letting them know what's going on.
Yeah, that would be huge. I mean, if we can pull that off.
It's possible, right? It's possible. It just takes a little energy and initiative, right? So, we've been at this for 35 minutes already. So, we've talked about a lot of things, changing your systems starting with dispatch, epi infusions, enhancing your cardiac arrest, blood products, airfield, ultrasounds, all of those things. So no matter what you're doing with your agencies, and you're both medical directors, and there's probably medical directors watching. I'm sure there's EMS chiefs or paramedics out there that want to make a difference in their system. So they want to put these things on. Take a product or take a topic and you institute it. How do you measure it? How do you know you're making a difference? Is it worth the money? Is it worth the training? Is it worth the effort? And you wanted to talk about a really good CQI program.
Yeah, so that's near and dear to my heart. CQI, quality assurance. I mean, so most of the agencies you go in, and even hospital emergency departments, peer review or quality assurance, whatever you call it, is really a chart review and a slap on the wrist. I mean, that's really what it comes down to. You walk away from it. There's a lot of times there's negativity. It's always pointing out what I did wrong and never pointing out what I did right, that kind of thing. So so the general thing in terms of looking at this, I think it adds tremendous value if you look at a system and you break this CQI / quality assurance down into two parts. The first part being the system, and you analyze data. So you go through all of your data. You say, how many calls have we done? Break it down by battalion or district. Where are we going? Which hospitals are we going to? What's our ROSC rate? What's our, looking at sepsis, STEMI, all the different alerts that we could look at for quality data. Procedures, you could break down your ROSC rate, you could break down your cardiac resuscitation into objectives of how long it took you to get epi on board. Did you have any pauses of chest compressions more than 5 seconds? So all this systems data is there for you. And I think members of the agency, they get interested in how the system's performing and how we can make the system better. And then the second part, you look at individual practice patterns and you say, okay, let's do chart reviews of high level cases. We look at, some of the alerts. We find some good cases where, man, this cardiac arrest was beautiful. The way you ran this was perfect. Thank you. And then, maybe some opportunities we look at too. And then after all of that, system analysis, individual practice patterns, you have your data. You should walk away from a CQI meeting with some action items. There's nothing worse than spending an hour or 2 hours of time. Everybody's together. We came up with a lot of things, and nobody tells the rest of the department what we learned. So we call these EMS action items. Take this information, put it out to the agency. Tell them, hey, there's 5 things we learned this month, and this is something that, we shouldn't be doing this, or we should be doing this more, whatever. And then hopefully if you look at your EMS action items over the course of a year or 2 years, you go, hey, you remember when this was a problem? It's no longer a problem. We fixed it. Now we have these other things we're working on. Look how far we've come. So it adds value. I think that's an important part of this whole thing we're doing here called, medicine, emergency medicine. It's not just the outcomes, like I said from the beginning, it's not just the clinical outcomes, but it's the outcomes that we have with our members, how they feel at the end of a career, saying, man, I really enjoyed my career because I felt so supported. And I always felt like I was part of a team. And it was never meant to break me down. It was always meant to make me do better. And then ultimately by doing that, I think you get better clinical outcomes. So it's
Yeah, I think we see that a lot. We see that in CQI and we say, oh, we did this right, or, we're seeing a trend and we try and fix it in that room. And it doesn't work that way.
Right.
There can't just be the key players. And I don't care if you have a department of 10 or do you have a department of 2,000. It needs to start in that room, I think. And then it's just, how do you, dissipate some of that info? How do you get all that information out?
Yeah.
And what's your plan to make some corrections? And they might just be small. It could be a memo. Maybe people don't understand that that's happening, and it didn't just happen to them at their station, on their shift, or their battalion, or so on. Or it's a training issue, or it's a product issue. The one thing, I was with an agency yesterday teaching, and I think the missing piece that I see quite a bit is hospital outcomes. If we bring a cardiac arrest into a hospital and they're not doing quality resuscitation, I think, now for me, I'm at a chief level, I can make that phone call and say, hey, we're recognizing this. We need to make some changes. Normally the medical just come kicking dirt and leave and go, I can't believe that happened at that ER. I think we're all one team, and we can't be afraid of not ruffling feathers, but making a difference for the better good of everybody, and everyone's part of that team, including the ER.
Absolutely.
Yep.
Yeah. I mean, look, we're partners with the hospital. So
Yep.
if we have a disposition where we say, hey, we're here to help you, we're here as your friend, as your ally, we want to make your, outcomes better, and it's the same thing. You can help us because we want to be able to promote a high, CPC 1 and 2 scores. And if we bring them to you and we know you're aggressive and you're going to give us that,
Yes.
we really like bringing patients to you. So, and that builds that symbiotic relationship between the EMS and the hospital. And it's a win-win. Everybody's winning,
I just today I sat with one of the local CEOs because, there's some issues. Obviously, there's a lot of boarding and this and that. And, he welcomed the fact that we were there concerned about our community. And that, we basically said, hey, we're partners in this community. How can we help you? You can help us. We're not here to complain about issues, but there are issues. How can we resolve them together? And he was, and in fact, he's new to the area. So he was happy that, we came to visit and spoke and really say, how can this is our community. How can we do it together? Jim, going back to the process issues, as you said, and the action plan, one of the things that I find many times in our CQI is, like we said, we sit in a room, we say, okay, this is what we have to do, and that. Then we come back a month or 2 months later, start talking about other topics or other issues that happened within those 2 months, but really don't go back to what we had talked about and how we were going to resolve those problems, right? So basically, hey, these are the action plans that we need to do, and now a month or two later, we're talking about other things, and really don't come back and see what did we do with the issues that we had 2 months ago. How did we solve them? Like Chief McGrath said, did we bring it out to the folks, on the ground? How did that, those little changes that we talked about, did those outcomes, turn out better and things like that. So I think that's really important. Every time there are action items, you got to come back and see what did you do with those action items?
Yes.
How did you make it better? Or what did you talk about? What, it didn't work out that way, the way we thought. Maybe we need to tweak our process again because we tried that for another month or two and it didn't really work out. Within that specific issue, maybe we need to tweak it again. So it's really important to go back to those issues because I think as folks on the ground, they say, well, we keep having the same problem. They say they talked about it, but we haven't really fixed it because we move forward to something else. But we really got to keep an eye on sort of on the ball. Hey, let's fix what we talked about.
Yep, agree, definitely.
Yeah, I think from the street person and people that are watching that are medics, I think you can make a big difference just by that relationship with the ER physician. For me, when we put on ultrasounds, if I go to our local physicians, our receiving facilities, say, listen, we're carrying this. This is how it works. When the crews come in with an abdominal pain, if you don't mind grabbing theirs and showing them how to see the gallbladder or do this, the more they get exposed to that, and then maybe next month when they bring in that patient, I want you to ask them where the ultrasound image is. And as they start doing that, then the crews will adopt it, because they know that the ER staff appreciates it. And, how many ERs don't even have our protocols? Don't even know what we do in the field, and everybody's busy. I get it. But, those are the things that I think make a difference in patient outcomes. Have you seen any agencies that may invite some of the ER directors to their CQI so maybe they're involved in saying, well, maybe we can make a difference on our end to help you with that outcome.
Right. That's a great point. Yeah.
And I've never seen it, but and they may not have time, but why wouldn't they? Because if they're trying to get community outcomes and it's really better if we bring them to their hospital and the patient survives or does well, it looks good for everybody. So I know they would want to, but that's really the thinking outside the box of, hey, why don't you come? And this is what we talk about. And I think, and the same way, if a nurse rode with our trucks for a little while, or some of our medics spent some time in the ER and realized that side of it, the same thing like you did walking into dispatch.
Yeah.
That's incredible. So we have a thing going across the bottom of your protocols. So I think it's really important for people to have immediate access to those. And we'll finish up with this. And I know you have an app as well that your systems, so your personnel can grab the most active protocol. So if you make a protocol change, they can click on it and boom, that is the most up to date. So the printed ones that they have from a year ago, we just consider to be old, right?
Yep.
So tell me about what you have up here.
Yeah, so you have the app and you have the website. So to your point about the emergency departments, so I also go around to the emergency department and say, hey, there's an app. So if you have a question about any agency in this county, for the most part, you can go to the app, click on it, and say, hey, what's your protocol? Like if the paramedics say, hey, well, that's the protocol. Really? You can open up your app and say, okay, if I'm a doctor and I say, you have that let me see the protocol. So I go, what's your agency? Okay, got it. Boom. Show me the protocol, and I can see it. And so then, because that again, to your point, is let's get the ED physicians on board with the protocols. Because most of the doctors in this county don't know what the protocols are. I mean, they really don't. So only way to get them is you got to give them an easy access to the protocol. So the app seems like an easy one, and then they can also log in from their desktop in the emergency and look at BrowardCountyEMS.org and to see all the different protocols.
Right.
You have them all that they're putting up there on the screen. So, I think that, and again, mutual aid, two agencies working together, if they need to know each other's protocols. So there has to be a place that all this information is there, that it's readily available and easy.
And this is simple technology. This is something that any agency, no matter where you are, how much money you have, this can be done. This is a great starting point, to make sure you're sharing and utilizing your resources. And there's, people like, I don't know, where do I start? Well, first of all, ask. You said, there's people everywhere that are willing to help. They'll send you their whole protocols. Here you go, change the title on the top. Knock yourself out,
Yeah, exactly.
They're not proprietary, they're out there. So you just need to tweak.
Yeah.
And know where to ask.
You put the protocol in a PDF. So if you whether you use PowerPoint or Publisher or whatever, you save it as a PDF, you can put it into the app. It's really not hard. And then you can hyperlink within PowerPoint or Publisher, whatever. You can hyperlink everything up for yourself, and then there you have it. So
yep. Great. And we're seeing now how it navigates, and it's very, very simple to access, and it's great. You did a fantastic job here with this, and hopefully everybody, can utilize these things and make changes, get recommendations. It's always nice to see what all the other agencies do.
Yeah.
To say, oh, maybe we should be doing this. There's nothing wrong with some copy and paste.
Well,
absolutely. I feel like that kind of competition makes everybody better.
Yeah. And at the end of the day, we go by Dr. Chepsky's, R&D department, as he says, right? Rip off, duplicate, because listen, it's out there, and luckily, and the great thing about, I think, our community is that we're willing to share, help. We know everybody has different ideas. Hey, that's a great idea. I'm going to use it, and whatever. So it's out there, and if it isn't, we all come together and try to figure it out as together,
Yep, absolutely. Well, gentlemen, I really can't thank you enough. This is great. I love spending time. We could sit and talk about this for hours, to make things different. So for those that were joining in, I really do appreciate your time. I hope you got something out of it. Like I said, we're back here the second and the fourth Wednesday of every month. You can go to any of our social media pages, Facebook, Instagram, LinkedIn, YouTube. Definitely go see us on Facebook. If you have comments, feel free to put something on there. Some topics you may want to see. We've had the Pride in Leadership a couple weeks ago. We did have the mental health part, which we will revisit for sure. We have these fantastic medical directors. We have quite a few topics coming up in line. So if you have suggestions or something you want to see, for sure, drop us a line so we can make sure we're meeting all your expectations. So Dr. Gandia, I really appreciate your time. I'll let you guys finish up before we're finished.
Yeah, first of all, it's, again, I feel like a old dad and proud of everyone here, and I'm so glad, to have everyone here. Now, the other thing too, Billy, as you mentioned with comics, please listen. We're new at this stuff, so anything you guys think we can do better, how to improve our podcast, how to reach out to more folks, and again, our website is there. Any comments or anybody. Because as we saw last time, actually, first one with Chief Downey, he goes, hey, one of my buddies called me from Germany that he saw this. So really, anybody who wants to reach out to us, anything we can help, not only here, anywhere, please feel free to do that. Again, we're sort of an open book at Braxton, and again, we're very, very proud, and thank you so much. And Jim, wonderful work, and a lot more work to do, and I guess we'll all be here to keep trying to do it as best we can. And thank you so much, brother.
Awesome. It was a real pleasure hanging out with you guys and talking. Thank you.
Thank you so much. And Dr. Roach, again, congratulations on the Eagles.
Yes, sir.
Those, please come join, see the gathering of Eagles at First There, First Care. You can get to that as well at firsttheirefirstcare.com. And you can see about the conference. It's in the middle of June here in sunny South Florida at the Hard Rock Hotel and Casino. And it's joined with our Fire Chiefs Association and finishes up with the Gathering of Eagles. Great week of education as well. Be sure to check that out. So thank you, gentlemen. And thank you all for joining, and we'll see you in a couple weeks.
All right. Thank you. Thank you again, Jeff.